Hi, welcome to Holy Redeemer's Joint Replacement Program. My name is Linda Beck. I am the Joint Replacement Program Manager, and I'm here to give you some education on the joint replacement class. I co-teach this class with myself and Amy Ring, who is the Director of Rehabilitation Services, and I am the Director of Surgical Services here at Holy Redeemer. Why are you here? You're here because you're getting the information that you need to have a successful joint replacement. This class is going to discuss everything from pre-admission testing to discharge to home. As part of our safe care protocols, when you come into the hospital for your surgery and for your pre-admission testing, we will ask you to be screened at the door. You'll have your temperature taken. You'll be asked some screening questions. Please make sure you wear a mask when you come in for your pre-admission testing and the day of surgery. You will also be going to the operating room with that mask on, and you will have a mask post-operatively in the PACU when you wake up from your procedure.
Please be sure to put on your mask covering your nose and your mouth anytime that a healthcare provider comes into your room. This could be one of the nurses, the nursing assistants, a physician, the person delivering your meal, or one of the therapists. This way, we both stay safe.
We're first going to go over the total hip replacement. Some common causes of a total hip replacement on the reason on why you need a total hip replacement is osteoarthritis, degenerative joint disease, a prior history of an injury or a fracture, rheumatoid arthritis, avascular necrosis, obesity or your body size, and certain bone tumors can lead to you needing a hip replacement. If you're wondering about why and how we do the hip replacement surgery, here's some basic information. This is the anatomy of a hip joint. As you can see, there's the acetabulum, which is the hip socket, there's the femoral head, there's the femoral neck, and there's the thigh bone. Here are two x-rays of a normal healthy hip and a hip that requires a hip replacement. As you can see on the left-hand side of the screen, there's a nice space between the femoral head and the acetabulum. There's a nice grayed out area. When you look at the x-ray on the right side of the screen for the arthritic hip, that space is obliterated and it is white touching white. White touching white is bone touching bone. Bone touching bone is what creates all the pain that you're experiencing. So how do they do a hip replacement surgery? After they get you into the OR, we get you into the OR, we position you on the table. The surgeon will then go in and surgically remove the femoral head, as you can see in the photo. The surgeon will then expose the acetabulum and place the acetabular component up into the pelvis. Then finally, they drill down the femur and place the femoral component into the femur. For those of you having a total knee replacement, some causes on why you need a total knee replacement is osteoarthritis again, degenerative joint again, a history of a previous injury or fracture, rheumatoid arthritis, overuse injury, and body size. And how they do the knee replacement, we always review the anatomy first. This is the basic knee anatomy. There's the femur, which is also considered your thigh bone, the patella, which is also known as your kneecap. There's some cartilage in the knee. There's the hyaline cartilage, and there's the tibia, which is known as your shin bone. Here are some x-rays of a normal healthy knee and an arthritic knee. In the normal healthy knee, you can see there's a space between the femur and the tibia. It looks great. There's no bone touching bone on that picture. When you see on the arthritic knee x-ray on the right-hand side of the screen, bone is touching bone. As you can see, there's no space and the space is obliterated. And when you have bone touching bone, that's what creates the pain. So how do they do a knee replacement surgery? After the surgeon, you're in the operating room and the surgeon exposes the knee. He surgically shaves down the femoral surface and removes all the arthritis. Then they glue the femoral component, they cement it on to the femur. The cement has antibiotics in it so that to help with any kind of infection that could occur. The tibia also then, as you can see, there's some rigid edges there on the tibia space where that blue line is. The surgeon also cleans up that area, surgically removes all the arthritis. And if you see in the next picture, they put this plastic tibial spacer and component, they cement that onto the tibia. As you can see, the femoral component is in place up top there, secured with the antibiotic lace cement. Then for the kneecap, the patellar surface is removed. They carve out all the rigid edges and they place a small patellar implant behind that. Now you're preparing for surgery. For pre-admission testing, we'll call you to have you come in for your pre-admission testing. What you will need to have done is some lab work will be done. An electrocardiogram will need to be done. We only accept EKGs from a cardiologist or done here in the hospital. We do not accept any EKGs from your primary care doctor. You will come in for a nasal MRSA swab, and we test it for MRSA. The other test that you will need to have done is a COVID test. The COVID test will not be done in the pre-admission testing department. That will be done as an outpatient testing department, and that is a separate phone call that you will get from the outpatient department testing you. Your pre-admission testing will be done 10 days prior to your surgery. The COVID test will be done within 3 to 4 days prior to your surgery. We put this slide in here just because we'd like to know if patients have any metal allergies. They are rare, but if you do have a known metal allergy, please let your surgeon know so that we can get a special components for you for your surgery. So the night before surgery, we're going to call you between 4 and 8 p.m. and tell you what time to arrive in the hospital. The time that we give you is 2 hours before your surgical start time. Please be on time. The nurse calling you will review all your pre-admission testing instructions. If you are arriving on an early morning start between 5:45 and 6:30 in the morning, we're going to ask that you come into the hospital through the ER entrance doors. Otherwise, any other time, you can come in through the east entrance or to the valet entrance of the hospital. Please remember the night before and the morning of, we're going to use the special soap, the chlorhexidine bath, the CHG bath, that the pre-admission testing staff provided for you when you came in for pre-admission testing. You have information on that in the bag that they gave you or that are accompanying the bottles of wash. So make sure you wash the night before and the morning of the surgery. Make sure you follow the instructions step by step. Please change the sheets the night before, your bed linens. Make sure you wear clean pajamas to bed. When you get up in the morning, go back into the shower, use the chlorhexidine as the directions advise. Let it sit on your skin for 5 minutes, rinse, get out, use a clean towel, put clean clothes on, and come to the hospital. Before the surgery, the nurse again will clean your surgical area, whether it be a knee or a hip, again with the surgical wash. Just remember, you're not to eat or drink anything starting at midnight before surgery. You can take your meds, as we told you, as the pre-admission testing staff told you, with a sip of water the morning of the surgery. Remove all body piercings and contact lenses. They cannot be in. If you're a contact lens wearer, please bring a pair of glasses and a glass case with you. No makeup or lotion should be applied the day of surgery. No chewing gum, no swallowing, no chewing any kind of candy of any sort. Do not bring any valuables, jewelry, cash, credit cards. Do not bring any medications with you unless that we tell you. The only medication that we request that you bring are eye drops or inhalers. If you should need cash or a credit card because you're going to use the EasyRx pharmacy with us, your ride home can provide that information and bring it home, and they can bring it to the hospital on the day of discharge. So the day of surgery when you come into the hospital, these are the couple things I want to review with you. You're going to check in on the 3rd floor, same day surgery. You're going to get your vital signs done and you're going to get your weight recorded. Sleep apnea, the nurses in same day surgery will review a sleep apnea assessment with you. They're going to go over your history with you one more time. They are going to go over your skin with you and assess you for any open rashes, wounds, abrasions. They will put an IV in. The nurses will review your home medication list and see what medicines you took the morning of and when's the last time you took your medications. And they will go over your allergies with you. We will review your allergies, and if any allergy that you have, an orange band will be placed on your wrist. Anesthesia will see you the morning of surgery also while you're in same-day surgery. The most common type of anesthesia for a joint replacement surgery is the spinal. We also give you some propofol, which is a medication that will keep you asleep during the surgery. For additional pain management, anesthesia will give you all the knee replacement patients an adductor canal block. The adductor canal is the space between the thigh muscles that contains a nerve. The anesthesiologist uses an ultrasound and provides some medication, some numbing medicine in that adductor canal space, which we then get additional pain management and temporary relief of pain. The adductor canal block generally lasts about 23 hours post-procedure. The surgeon will also see you the morning of surgery. They'll review your consent that you signed and the procedure one more time with you. They'll answer any questions you have, and they will mark the site of the surgery. By marking the site of the surgery, the surgeon will use a purple marker and put their initials on the leg or the side that they're doing for the surgery. Also, as a safety measure, we do perform timeouts prior to you going into the operating room. And there's a timeout period when you leave same day and before we do the surgery. That timeout period, we ask you, what is your name? What's your date of birth? Why are you here? What side are we operating on? The nurses, while you're alert and awake before you get any anesthesia, will include you in this timeout period so that you can participate with us. Once you get back to the operating room, there's another timeout period that the room does, that the care providers do, and they review who is in the room, what is the date of birth, and what we're doing. This is a part of a patient safety initiative. So during surgery, a single joint replacement, if you're just having one knee done, usually lasts about 2 to 2.5 hours. If you're having both knees done at the same operative time, that lasts 3 to 3.5 hours. You can expect your time in the recovery room to be 2 to 3 hours in length before you get transferred out to the floor. Post-operatively, what you can expect to experience in the recovery room, you'll have a heart monitor on, you'll have an IV in for IV fluids, you'll have the pneumatic compression pumps on your legs. They are on so you do not get a blood clot while you're here with us. You'll have an ice pack on your incision side. You'll have the nasal cannula in your nose giving you oxygen, a pulse oximeter on your finger, which measures your O2 oxygen saturation. You'll have a blood pressure cuff on your arm, which will be taking your blood pressure in the recovery room every 15 minutes. And you may have an incisional drain-in or a catheter in your bladder. That is surgeon specific. The catheter in your bladder will drain your urine, and most times it is discontinued the following day after surgery. Hip replacement patients may wake up with a hip abductor pillow between their legs. Amy will review later on in the class the purposes of the hip abductor pillow. So the day of surgery, everybody is out of bed, walking day of surgery with physical therapy. They come and see you the day of surgery and get you out of bed. Our post-op, the doctor will contact you in light of social distancing practices and not having family members in the building. The surgeon will contact your family members immediately following the surgery and give them an update. After recovery, you will be transferred to the surgical nursing unit. The name of that unit is 3 North. You can visit the holyredeemer.com visitors website for the latest visitor information regarding having family come into the hospital. Pain management. So how we manage pain along with the adductor canal block, we also give some oral medicines prior to you going to the OR. We use a multimodal approach to pain management. We give you a narcotic, a non-narcotic, and extra strength Tylenol prior to going to the OR in same-day surgery. The team collaborates with you along your path while you're here to make sure that your pain level is at a 4 or less on a scale of 1 to 10. The adductor canal block for knee patients also provides an additional level of pain management. One thing you have to remember with taking narcotics, opioids can be very constipating. So we do help to manage that with giving you stool softeners, keeping you hydrated, and PT getting you up and moving. Some complications regarding joint replacement surgery, but they're the complications for any surgery, are blood clots, pneumonia, compromised skin integrity, and infection. Blood clots are a deep vein thrombosis, which is a DVT, is a deep vein thrombosis found in the arms and the legs. A PE is a pulmonary embolism, and that is found in the blood supply to the lungs. So what do we do to prevent you from getting a blood clot post-operatively? We have you out of bed and walking. We have you wearing your compression boots always while you're in bed. And you take your anticoagulant as ordered. Everybody will be placed on an anticoagulant post-op. That anticoagulant can be aspirin, Coumadin, Lovenox, Xarelto, Arixtra, or Eliquis. You will be going home on a blood thinner. We highly recommend you getting up and moving with assistance while you're here with us. So pneumonia is another complication we like to keep you educated on. The reason why you can get a pneumonia is because you're not taking big, deep breaths because you're taking on narcotics. So people have a greater risk of getting pneumonia when they're recovering surgery or had any kind of sedation. Additionally, people can get a pneumonia if they have any kind of respiratory disease. So how do we prevent you from getting pneumonia? We give you an incentive spirometer post-op. In the PACU, you will begin to use that incentive spirometer. We limit your time lying in bed. We have you sit up and get out of bed into a chair. And again, we have you getting up and moving as frequently as possible. Your skin, probably wouldn't think that your skin would be a possible risk on having a joint replacement, but prolonged time laying in bed in the same position can lead to a risk of skin breakdown. There are bony spots on that are increased risk for getting skin breakdown, and that's your hips, your buttocks, and your heels. So while you're in bed, the nurses will encourage that you turn and reposition frequently. We would like you to decrease your time in bed, and the nursing staff will do frequent skin checks on your on those bony prominent spots. Again, you can see the main thread here for the risks of having a joint replacement surgery is getting up and moving. And finally, infection. What do we do to prevent you from getting an infection post-op? We give your antibiotics prior to 60 minutes prior to the incision time, and we stop it within 24 hours. We do not use a razor to shave the hair off your skin of the surgical area. We use a clipper because razors are known to cause little nicks in the skin. If you're on a beta blocker, we make sure that you are taking them prior to surgery before you go into the operating room. We keep the body warm during the surgery. In the operating room, we have a heated blanket that blows hot air onto you. And finally, we use a silver dressing called a Mepilex dressing that stays on your incision line for 7 days post-operatively. That dressing provides a slow release of antibiotics onto your incision line to help keep it safe and to minimize the infection. You will be removing that silver dressing on 7 days after your incision when you're home. You have to remember that an infection in your body can lead to an infected prosthesis. Prior to surgery, your blood pressure needs to be controlled. Your diabetes should be under control we require a hemoglobin A1C of less than 7.5. If your hemoglobin A1C is greater than a 7.5, we cancel the surgery and reschedule it to a time for when your hemoglobin A1C is below 7.5. We require all patients to stop smoking, as smokers have a higher risk for infection. If you have a history of MRSA on your skin somewhere, please tell your surgeon about that, as we change the antibiotic prior to going to the OR. The 5 days before the surgery, do not shave your legs. As we talked about before, razors leave a small nicks in the skin, and that creates a pathway for a possible infection to occur. After surgery, do not touch your incision line. Use a clean washcloth and towel every time you take a shower. Use liquid soap. Don't share the bar soap. Don't use bar soap, as the bar soap, when it sits in the shower, has the potential of sitting in a pool of some germ water. Wear loose-fitting clothing, nothing rubbing on the incision line. And if you have a pet that sleeps with you, a dog or a cat, now's the time. You probably should relocate them or relocate yourself until the incision site is healed. Your dog or cat should not sleep with you. Do not soak the incision in a bathtub, swimming pool, or hot tub until your incision is completely healed. Your surgeon will let you know when you can do that. If you become sick, seek medical attention immediately. Practice good oral hygiene. There's some folks in here who had to probably get a dental clearance prior to coming into having their joint replacement surgery. Always let your dentist know when you go to the dentist after the joint replacement that you've had a joint replacement, because sometimes they require you to take an antibiotic before your appointment. And please always remember to wash your hands, wash your hands, wash your hands. So I'm going to turn this over now to my co-partner here, Amy Ring, and she'll talk to you about what you should bring for your hospital stay and exercises.
Thank you, Linda. Hi, everyone. My name's Amy Ring. I'm the Director of Rehab Services here at Holy Redeemer Hospital. I am a physical therapist, and I'm going to start to discuss things to bring for your hospital stay. Now, you will be wearing a gown when you first have your surgery, but you will be wearing regular clothes the next day. So we ask that you bring rubber-soled, non-skid, closed-back shoes. Sneakers are very appropriate. If you have dentures, hearing aids, or glasses, please bring them. We want you to eat, hear, and see. Bring loose-fitting, comfortable clothing. You will have swelling in your leg. That is not unusual, and we want you to be comfortable. So if you want to wear shorts, sweatpants, yoga pants, anything like that is perfectly fine. Please bring books, magazines, electronic devices with chargers. We do carry all the main channels on our TVs, so you will be entertained. And if you do have a CPAP, please bring one if you use one. We do want you to start preparing for surgery at home. Please get your rolling walker before surgery. You can ask your orthopedic surgeon for a prescription, and you will be able to get your walker from a CVS, from a durable medical equipment company. Any of these is perfectly fine. Have the person who's picking you up bring the walker with them on the day of discharge. Please do not bring it with you on the day of your surgery. All walkers look alike, and sometimes they have a tendency to get lost. We do not recommend rollators. Rollators are the four-wheeled walkers that you see sometimes with people using that have seats. We do not recommend these following surgery. Consider installing handrails, especially on any indoor or outdoor steps if you have time to do that. It does make going up and down steps much easier. Make sure that you have a sturdy chair to sit in. Test out your furniture. Make sure that it's easy to get up and down from it. Many times we have very comfortable furniture, but we have a tendency to sink into it. If you sink into it, it's harder to get out of. Recliners and couches are not recommended, especially after hip surgery, due to the angle of your hip. So make sure that you have a chair that's comfortable, that you're able to sit in and get out of. One of the most frequent questions is, why do I have pain? The obvious answer seems to be that you have pain because you just had major surgery. However, the cause of that pain is usually probably something different than you're thinking. The most common site of pain after hip and knee surgery is behind your knee or on the sides of your knee. And this is why this happens. Your muscles attach to your bones by tendons. When we're young and we're all running around, our bones are in a great position and we have what we call a good length-tension relationship with our muscles. This means that everything's lined up properly. But what happens is, after all the wear and tear, the sports that we play, accidents that we're in, all those crazy things, that the day the doctor says that we're bone on bone, you have to think about the fact that that bone is not the ideal length. It's actually shortened. But your muscles are still attached to the bone. So what happens is a lot of the muscles shorten, especially the muscles behind your thigh, right? Your hamstring muscles and your calf muscles. So what happens is that they're shortened, but once you have surgery, you have a good length tension relationship again, except, your muscles have to adapt, and they don't adapt overnight. So the pain is caused from these muscles on a continuous stretch, which you feel behind your knee and on either side, as I said before. What helps these, though, are exercises that we review with you, that we have you do before surgery and after surgery. It may take some weeks to get these muscles into the right length that we need them to be pain-free. But your pain will keep getting better and better and better the more that you do the exercises. So I'm going to show you a whole bunch of exercises, about 5 altogether. And these exercises, like I said, are ones you're going to do before surgery, and they're going to do them after surgery. The first one we talk about is ankle pumps. This is basically lifting your foot so that your toes come up and then your toes point down. It stretches the calf muscle or the gastrocnemius muscle in the back of your leg. I'm sure it feels tight a lot of times, especially when you first get up to start walking. You can do this together, so both feet at the same time. You can do it in sitting, or you can do it lying down, whichever is more comfortable. When you do the exercises, I'm going to ask that you do them 3 times a day, 10 times each exercise. Now, if an exercise seems pretty easy and you feel pretty good after doing it, you can do it more frequently, but I don't want you to do so many that you feel sore or tired. The other thing that's important about exercising is I usually tell people to do it when they first get up in the morning, because that's usually when you feel stiff. We all know how everyone kind of limps and gimps their way to the bathroom every morning. Sometime around lunchtime, and then around dinner time. I don't recommend doing exercises right before you go to bed, because remember, you're stretching tight muscles, and I want you to be able to sleep. I don't want you to have any pain from doing any exercises, and that's going to stop or prevent you from having a good night's sleep. So these 2 exercises are your quad sets and your glute sets. We call these isometric exercises because it's not like you have to pick up your legs or anything. You're going to tighten your muscles. So the quadriceps are the big muscles in the front of your thigh. It's actually made up of 4 muscles. What you're going to do is you need to have your legs straight. You can do this either lying down, or you can do it in what we call long sitting. What long sitting is that if you are sitting in a chair and your feet are on a hassock or an ottoman, that's a perfect position to do it in. You could be sitting sideways on your couch where your back is supported by the end of the couch and your legs are on the couch. That's fine too. What you're going to do is with both legs, you're going to press the back of your knees into, or towards, I should say, the ground. So you're going to press it down, you're going to hold it for a count of 3, and you're going to relax. And you're going to feel that big muscle in your thigh tighten up and then relax. Now, one note, after surgery, when you go to do these exercises, you may feel that your operated leg is not tightening as much as what we'll call your good leg. And that's okay, because those muscles just have to get their strength back. So that's not unusual. So the quad sets, you're tightening those up, pressing down towards the floor, okay? Your glute sets, they're your buns, okay? Whatever you want to call it. Your bottom, your hiney, your buns. You want to squeeze them together. You can do this anywhere. You can do this sitting in your car, preferably at a stoplight, not while you're driving. You can do it sitting in a chair. Anytime during the day, you just squeeze those buns together, hold them, and then relax. And people always ask me, why do I care about my buns? Well, you care about your buns for a lot of reasons, because other people are looking at them, number one, so you want to look good. The other thing is that your gluteus medius is a major muscle for walking, and that's one of the muscles that make up your buttock muscles. So we want to make sure that that's nice and strong and ready to get you walking again. The next 2 are what we call a long arc quad and a short arc quad. As you can see in the picture, you want to sit in a chair with your feet flat on the floor, and you want to lift one leg at a time, just up so that it's straight, and then back down to the floor so your foot rests on the floor. When you do exercises, you want to make sure that they're slow and controlled. It is not about how fast you can get an exercise done. It's all about control. If you do it too fast, you're actually not activating all of your muscle fibers. So you want the biggest bang for your buck. So you want to make sure that you lift the leg up in a controlled motion and down in a controlled motion. We are also equal opportunity exercisers. That means you need to make sure you exercise both legs. If you're just having surgery on one leg, you still have to exercise on the other leg, because that leg has to help you support yourself as you're walking and climbing steps and everything. So you need to have it as strong as the other one also. Now, the short arc quad, what you want to do is you want to be lying down. This is similar to, you can either be lying flat, as in the picture, or you can be in more of that long seated position where your back is against the chair, your legs are on, say, the couch, anything like that that you're comfortable with. You can be sitting up a little bit in bed, that's fine. You want to get a towel or a pillow, something that you can roll, that you can place under your knee, as in the picture, so that there's a slight bend in your knee. And what you're going to do is you're going to literally pick your foot up. It is called a short arc quad because it is a short arc that you are moving your leg in. You're literally just picking it up that little distance and bringing it back down. Again, in a slow, controlled motion. And what's interesting about this exercise is people always think that it's going to be super easy to do. And a lot of times, this is one of the hardest ones to do, especially after surgery. Do not worry if you go to do this exercise and you're not able to lift your foot up off the bed initially. The muscles come back, they do come back nice and strong, and you will be able to lift it up. One of the reasons why we have you do these exercises prior to surgery is to teach your muscles what it's supposed to feel like when you exercise. This way, after surgery, because you have decreased sensation initially after the surgery, and just, you've had a big surgery, it affects your muscles and everything. We need to wake them up again. But muscles have something called muscle memory. If we can train them prior to surgery to know what is expected and the position to move in, they come back quicker after surgery. So remember, when you do the exercises, you want to do them 3 times a day, 10 times each. So speaking of physical therapy, as Linda said, you will be out of bed and walking on the day of surgery. We come to you no matter what time you come out of surgery. You're going to have 2 therapists come into your room, and we will be smiling because we'll be happy to see you. And we're going to check your vital signs. We're going to make sure that you feel okay, and we're going to get you up and see how you do walking. There are some days that people can only sit on the side of the bed. Sometimes people are only comfortable standing just because they don't have the sensation back in their leg yet from that adductor canal block we talked about. And sometimes people can walk 200 feet. Whatever works best for you is what we do. You will have physical therapy twice a day, and we focus on transfers. So can you get in and out of bed? Can you get in and out of a chair? Can you walk with a walker? Can you do steps if you need them? We work on your range of motion, and we review the exercises that I just went over with you. You also have occupational therapy. The occupational therapist will see you the day following surgery. You will have occupational therapy once a day. They will focus on what we call activities of daily living. These include bathing and dressing. Can you get on and off the toilet? Can you get in and out of a tub or shower? We have adaptive equipment that we can show you how to use. And by adaptive equipment, we have things called leg lifters, which is like a loop that helps you lift your leg on and off the bed. We have sock donners to help you put your socks on and off. Multiple things that the therapist will review with you, and either we offer some of the equipment if it's what works for you. If there's something that we don't have or offer, we will absolutely tell you how you can go about getting it. We also work on arm strengthening exercises because you do use your upper body a lot when you have surgery on your lower legs, just to help you get up, out of bed, and out of chairs. For those of you that are going to have a total hip, you do have precautions. Now, there are 2 types of total hip surgeries. There is the anterior approach, and there's the posterior lateral approach. Your surgeon will tell you which type of surgery they are doing. If you have the anterior approach, these precautions are not meant for you. If you are having the posterior lateral approach, which means your incision is back more towards your buttocks, this is more of the traditional hip surgery that occurs. These precautions are the ones that you need to follow. The first is we do not want you to cross your legs, whether it is sitting, lying down in bed. A lot of times people are ankle crossers. I know that I do this. A lot of times if I'm in bed and I'm reading a book, I don't even think about it. I cross one foot over the other. You cannot do that after surgery. We don't want you to turn your toes inward. And a lot of times people are like, well, I don't turn my toes inward now. Why would I do it after surgery? Sometimes after surgery, certain muscles may be weaker than they were before surgery, which means your toe may come in a little bit. But don't worry, your physical therapist will absolutely tell you that you're doing that. And the third thing is, we don't want you to go past 90 degrees. So when you see in the picture, don't bend over. So sitting in a chair with your back supported, your bottom in the back of the chair, your hips are at 90 degrees. If you go forward, you break that 90 degrees. If you lift your knee towards your chest, you also break that 90 degrees. So the occupational therapist and the physical therapist go over how to do all your activities that you need to do while maintaining your hip precautions. The other thing is that hip precautions are not forever. Usually hip precautions are about 6 weeks to possibly 8 weeks. When you have the follow-up with your orthopedic surgeon, they will tell you how you're doing and when you can stop your hip precautions. Now, this big blue reminder here is called a hip abductor pillow. Not all surgeons use it, but some of them do. So if you wake up and you have a big blue triangle between your legs, it is just to prevent you from crossing your legs. As you know, a lot of times, when you sleep or you're just not thinking about it, you can cross your legs without even a thought. So this is just a reminder while you're in bed to be careful about how you're just positioning. When you're out of bed, you don't need to use this unless you're more comfortable. You always can if you want to, but it's not mandated. It's usually when you're in bed and the chances of you nodding off and possibly crossing your legs can occur. As a reminder, you are going to be using a rolling walker after surgery. Another question that people often have is, but how long do I have to use a rolling walker? Initially, you use it most likely for about a week. Some people may use it for 4 weeks. It really depends on how you're progressing with your physical therapy. You did this surgery so that you would be able to walk and do all the things that you wanted to do. You don't want to transition too soon to a cane or to no device if that would cause limping or any kind of what we call an antalgic or painful gait. So the physical therapist will help guide you for when you go from a rolling walker, then to a standard single point cane, and then to no device at all. But like I said, sometimes people use a rolling walker for a significant amount of time. It's however you're progressing, however support you feel you need. The other two pictures are what we call the 3-in-1 commode. A lot of times, especially after hip surgery, you need a higher seat so that you don't break those hip precautions that we talked about. What's nice about the 3-in-1 commode is that the legs are adjustable. As you can see in the far picture, you can remove the bucket and actually have it sit right over your regular toilet so that you have something to push up from. Towel bars do not count as something to pull up from because they can come off the wall, which is a whole nother problem, right? So please have your rolling with you before surgery. As we discussed before, whoever's picking you up at discharge will be able to bring the walker with you, and then you'll have it to help you get into the house. A few more household modifications. So if you have a pet, whether it be a dog or a cat, you want to be aware of where the animal is when you're going to come into the house. So here you are after surgery, you're coming into the house, you now are using a rolling walker. Your animal's going to be very excited to see you. You don't want the animal to be jumping up and scratching you possibly or knocking you down. They're excited to see you, but you don't want anything like this to happen. What we recommend is that if you could have your dog or cat placed in a room away from you so that when you come in, you can come in the house safely. You can sit in a chair. A lot of times what we would tell you is get a pillow, put it over your incision so there's no possible way that they're going to accidentally scratch your incision, and let them in. They'll be more than happy to see you. Remember to use chairs with armrests, and please don't use chairs with wheels. That's a lot of problems there when you go to sit in a chair and all of a sudden it starts wheeling away from you. Look around your house and see what kind of throw rugs you have. A lot of times throw rugs are beautiful to have in your house. The problem is they can get caught on the back of the walker. So the front of the walker usually has bigger wheels. It can go over the carpet, but all of a sudden you'll realize that you're dragging that throw rug behind you, and we don't want you to trip over it. If you aren't able to roll them up and put them away for a little while, make sure you're using a skid-resistant backing. We don't want you to catch your foot on that. Remember, you're not lifting your foot usually as high as you usually are until those muscles get stronger, so you want to use every precaution to stay safe. Just take a look around and make sure they're isn't any like wires. Sometimes we do things like we plug lamps in a certain way and we don't realize it's right in the route of traffic. So just be careful about your house. Take a look with fresh eyes. Ask someone else to come in if you want to, just to make sure that there's not any clutter to reduce any kind of fall risk. Night lights are your best friend. Anyone who doesn't get up in the middle of the night to go to the bathroom, you're really lucky. For all the rest of us, a night light is a great option to have. It lets you see where you're going. So in case someone had thrown something on the floor, like a pillow, or if part of the cover, the bed covers on the floor, it's not something that you're going to trip over. Make sure your handrails for steps are secure. I always say give it a little test. So hold on to your handrail and give it a little shake. If you're holding it in your hand after you shake it, you probably need to tighten it. If you have to vacuum after you did it because things fell off the wall, look into getting that more secure. If you don't have handrails, consider them having installed prior to surgery. They really are a big help when you go up and down steps. So let's talk about discharge. So our length of stay is typically 1 to 2 days, including the day of surgery. It's amazing, but 90% of our patients go home really well. It's just amazing how well patients do after surgery. You will have a home medication list. What we do is we take all the medications that you had listed and told us about before your surgery, and then anything that has been added, changed, or deleted is all compiled into one new list. We make sure that list is printed out to you and is reviewed with you before you go home. As Linda talked about previously, you will be on a blood thinner and you will have some type of pain reliever. You will go home with some type of visiting nurse association services. You will have a physical therapist come to your house. The therapist comes out the next day, no matter what day you were discharged, including weekends. If you're discharged on a Saturday, your physical therapist will come out on a Sunday. If you come Tuesday, they'll be out on a Wednesday. The physical therapist at home will take a look at your house, make any recommendations, and will continue to progress you through your walking, your exercises, all the strengthening. We do offer Holy Redeemer support services at home. Sometimes people need a ride home. They want someone to be with them to help them get their medications, maybe do some cooking, some laundry, just little things around the house. We do offer that for a fee, so we do have more information about that if you're interested. You will progress to outpatient physical therapy. It's not done just with the hospital services and home services. You will continue your outpatient physical therapy. When you follow up with your orthopedic surgeon, he's going to give you a prescription. You can go to wherever you're able to go. Some insurance have you go specifically to a certain place. We offer physical therapy in numerous places in the Holy Redeemer Health System. Outpatient therapy can last really from a few weeks to a few months. It really depends on what your goals are and how you're progressing. We do have an outpatient pharmacy located in the hospital. This is for your convenience. We have a program called Meds to Beds. You can fill prescriptions that you need a discharge from the hospital. What happens is that prescription is given to the outpatient pharmacy. They actually come up with a bag with your medications and deliver it to you prior to going home. We do recommend that payment is brought in by family and friends at the time of discharge. As Linda had spoken about earlier in the presentation, we ask you not to bring valuables into the hospital, but by all means, the family can bring in a credit card or cash and they can pay for the medications. It's a nice option. The other thing with Meds to Beds, not all your prescription will need to be filled at the Holy Redeemer Pharmacy. We can get you started with your first part of your prescription, and then it's transferred to your outpatient pharmacy that you use, whether it's a CVS, a Walgreens, so you can continue to get your medications through your regular pharmacy. Thank you so much for viewing the joint replacement classes with us. If you have any questions, please contact your provider. We look forward to seeing you soon.